guys, and welcome back to the Rotation Diaries. My name's Kris, and this week I'm going to be walking you through what was probably my favourite rotation in the hospital system, obstetrics and gynecology. If you're interested, of course, please keep watching. But don't forget to give us a like and write a comment. What do you want to see from me next? I've only got 3 rotations left, including this one, so this series will come to a close very soon. I really want to hear from you. If you're not already, please click subscribe and hit the bell if you want to know every time I post. If you haven't figured it out already, I post every Wednesday at 2 p.m. Eastern Standard Time. That's Australian Eastern Standard Time, mind you. Alright guys, let's jump into it, obstetrics and gynecology. So I already mentioned it's one of my favourite rotations, but let me preface it with it was probably the most stressful rotation I ever had. You think, stress, really? You liked it? I loved it. I flirted with doing obstetrics and gynecology as my actual career so much when I was in this rotation. I loved it as a student, but my God, doing it as a doctor is so different. I still really loved it, obviously, but I ended up in GP, so you can kind of tell that I wasn't swayed enough. But if you want to know why, well, that's why I'm here to tell you about it today. Oh boy. So how do I condense my ONG rotation down into a 10-ish minute video? Great question. So I did ONG twice, but technically only once. So I did 10 weeks, which was fantastic. Then I went into my next term, which was anesthetics, but then I got recalled back into ONG because of a lack of people to work in ONG. So ultimately, I think I did about 13, 14 weeks, thereabouts. So, you know, experienced. Not really. So this is actually the first video dedicated to my junior house officer years. So whilst by this time I'd already done general medicine, every other video I've done so far in the Rotation Diaries has been as an intern. So this year I'm a JHO. If you're thinking, what the heck is a JHO or a junior house officer, how's that different? I do have a video explaining all of that, which I will link down below. I think the easiest way to describe my ONG rotation is to separate it into the different areas. So sometimes we would be on the wards, sometimes we'd be in clinic, and sometimes we'd be in theatre. So when I was on the wards, this is the same old story. I'd get there early and I'd do the handover sheet. The ward, however, is separated into 2 different areas, the general obstetrics and gynecology ward and the birthing suite. So in the general obstetrics and gynecology ward, we would look after people after they'd delivered their babies, before they went in for a gynecology surgery, and after they'd come out of their gynecological surgeries. So it was kind of mixed. We had it, the ward was pretty physically separated, so anyone who just delivered a baby was in one area, and anyone who was really there for surgery or for medical reasons were in another. The birthing suite was obviously running 24/7, and sometimes it would get really busy. I think I counted at one time we had 8 or 9 labouring mothers, which I know doesn't sound like a lot if you come from a tertiary centre or from a dedicated ONG hospital. It was a lot for us though. I come from a small hospital, I think, please remember that. So on the wards, when I was doing the ward, not the labour ward, it's the same old story you've heard before. I would get there early, do the handover sheet, go to handover, get a list of jobs to do the ward round, see the people, do the jobs, and discharge people. Really, by this point, I kind of feel like a broken record. Because we had quite a few people on the ward and quite a few doctors working as well, we would often spread out, and I'd do, you know, beds 1 through 3, or 1 through 5 or whatever, and then I go and talk to the consultant. So I really started to get my feet wet, as it were, when it comes to trying to do more than just that secretarial stuff. I did a lot of internship. So interestingly, very rarely did I stay on the wards. Quite often the ward intern or the ward junior house officer would then go into clinic. I will talk about clinic in a little bit. I'm going to now step into the labour ward. So the labour ward, as it sounds, is a ward where we had labouring pregnant people waiting for the delivery of their baby. In one little area, we would have the assessment area. So if anyone thought that they might have started contractions or thought that they were you know, having a little bit of leakage, like their waters were about to break, or if they weren't feeling baby as much, or they just wanted to be reassured, we had a CTG, which is the way that we look at both the contractions of mother's uterus as well as the heartbeat of baby. And we would also have an ultrasound. So people would come in there for those sort of things, and we would also have women come in for inductions. So induction of labour is where a woman is not yet in labour, any stage, active or otherwise, and we would induce them by a number of methods. I'm not going to make this a dedicated video on different obstetrics and gynecology things, but essentially it was either physical or medical things that we could do. Outside of the assessment unit, we would then have the labouring people. So people quite often would have a midwife carry them through the whole of their labour, and we doctors would only step in if the midwife wanted backup or reassurance, or something looked like it was about to go wrong, or something had gone wrong. Very rarely that happened, thank goodness. The thing in gynecology and obstetrics that I learned is nothing goes wrong until it does. And when it goes wrong really wrong, really badly. So we'd had several women in labour, whether that's just the slow dilatation of the cervix or the active pushing stages. If anything went wrong, obviously we would step in, and by we, I mean me and the registrar who was on call. So the labour ward quite often wouldn't have a consultant on the ward, it would have a junior house officer, rarely an intern, usually instead of a junior house officer instead of with, and also they would have a registrar on board. If things went to then we would go up to theatre to do emergency caesarean sections, but again I would very rarely be doing this because that was in the hands of the registrar and the consultant. That's not to say I didn't assist though, I would quite often assist in caesareans and I quite like it. There was one surgery I had to learn and nothing else, it would be a caesarean. So you can imagine that the time on the labour ward really depended on what the heck was happening. So sometimes if a person tore when they were delivering their child, I'd go in and suture them back up. Tears can vary from a very small tear requiring very few stitches to a full-on 4th degree tear, which goes from the vagina to the rectum, including both of those orifices, and they would all go to theatre. So I obviously wouldn't do those ones. I got pretty confident in doing 1st and 2nd degree tear repairs. Mind you, 1st degree tears quite often didn't need anything. Your body heals amazingly. I was quite lucky because I was so enthusiastic and loved obstetrics that I got to be involved in a lot of the deliveries involving ventouses and forceps. So ventouse is basically vacuuming out the baby using a little kiwi cup or a different type of cup. I think kiwi's the brand. And a forceps delivery is basically using salad tongs to get baby out. I'll try and insert some pictures, but nothing too gross because it is very confronting. Of course, because I was so junior and I had no prior obstetric experience behind me, I wasn't in charge of these at all, except for the 4 nights I did overnight. So at the very end of my term, I got stood up unofficially, I suppose, for about a week because we had no registrars or PHOs around. They essentially stood me up to be a PHO, so I would do 4 nights of night shift. So again, I was very, very well supported, and the consultant that was on with me lived literally 4 streets down the road. So if I thought, oh, I think something needs to happen, she would be in her car and be there within like 3 minutes. 3 minutes is a very long time, mind you, and I only really called her in twice, I think, in those 4 nights. But yeah, that was, we'll get there. It was definitely a time. If I wasn't on the wards, labour or otherwise, I'd quite often be in clinics. So we would have a morning clinic and an afternoon clinic. And 99% of the time, the morning clinic was the antenatal clinic. So this is the hospital clinic where pregnant women would come, and I loved it. To this day, my favourite consults ever involve pregnant people. I love pregnancy. I've never been pregnant myself. It's on the cards for one day, but I love working with pregnant people. I love as a GP when people come in and they say, I'm pregnant. Oh, it's so exciting for me. That being said, I'm really open, and if someone comes to me and they're not happy about being pregnant, I will support them in every decision they make. This video is not about that, but I just wanted to make that really clear. But antenatal clinic. We would have people come in, usually from the 20th week of pregnancy, and we would do things like their height, their weight, their urine test, see how baby's going, maybe listen to baby's heart rate, measure them up, talk about their symptoms, talk about what tests are needed next, and support them wherever needed. Pregnancy is not just a physical thing, it's also an emotional thing. And there's a lot of things that go on in the psychology of a pregnant person that we were really well trained in. So I think most people have heard of things like postpartum depression, but being pregnant takes a toll on you. So in pregnancy, you can be known as high or low risk. I quite often would only deal with the low risk pregnant people, but sometimes I would help out in the high risk clinic as well. This was a little bit more interesting. So usually the high risk clinic involved people with gestational diabetes, gestational hypertension, preeclampsia, or very high risk pregnancies for other reasons. Twins and triplets were always considered higher risk because your risk of everything doubles. So, you know, again, not going to go into a lot of detail, just telling you the basic. So that was our mornings, was usually the pregnancy clinics, and I loved it. The afternoons were all gynecology related. So people would come in with heavy menstrual periods, with pain during sex, with suspicious lumps and bumps, with previously abnormal pap smears or cervical screening tests. Side note, I've done a video on that too, down below. Gynecology clinic was less exciting to me, but it was very, very, very interesting. It was definitely one of the most useful clinics to have worked in before working in general practice. Yeah. The final part of my rotation that I've really briefly touched on was theatre. So very rarely would we be able to go up and assist in theatre, but when we did, it was mostly for hysterectomies or other removal of organs, or cesareans, and I loved cesareans, I really did. They're very messy. They're not as simple as they look on TV. It's not just incise and oh my gosh, there's a baby. There's pulling, there's tugging, there's ripping. You've got to suction up so much fluid. If your waters haven't broke, that's several liters of amniotic fluid that we've got to suck up to, and it just gets everywhere. But it's beautiful, I promise. How am I going to condense the highlights into one little segment? The whole rotation was a highlight for me. Yeah, there were lowlights and we'll get there, but it was amazing. Pregnancy and delivery is amazing. Being able to help people if they did have heavy periods, not experience that anymore, incredible. Hearing baby's heartbeat for the first time, so touching. Giving someone their child that they've carried for 9 months, oh, it warms my heart. There are so many highlights in ONG, just so many. It is such a rewarding and fulfilling rotation. But of course, there are lowlights. So the lowlights of the rotation, there were a few, which you think, really? You've been so happy so far in this video. But there were, and that's kind of the dichotomy of medicine, really. A few of the lowlights was a late term miscarriage, so someone who was nearly ready to deliver miscarried, and the baby was born stillborn. It was very touching and very eye-opening, and I learnt a lot in that time. So that was definitely a low light. We didn't have any maternal deaths, which was fantastic, but it's a chance. We had a few really heavy bleeds and a few people that we thought might end up in ICU, but luckily we didn't, thank goodness, but it does happen. And then the other low light was being stepped up as a PHO when I was only a JHO. I know I mentioned it as a highlight, you know, maybe a couple of minutes ago, but it was terrifying. I've never been so scared. I was so proud and privileged that they would consider me to work that position, and I was so eager. But oh my God, I don't think I have ever been so scared. Ever. It went really well, so you know, yay. And I know that if I went back to do it again, it would be just as scary, but I would come out just as fine. But yeah, oof, I've never been so stressed. Tips for the rotation. If you're doing an obstetric and gynecology rotation, definitely get familiar with CTGs. CTGs are nothing like ECGs. They're really, really, really easy to interpret if you know how to do it, and are crucial on any obstetric ward. So learn what the dips and the troughs look like. So learn what the peaks and the troughs mean, what they look like, what a normal timing is, that sort of thing. Really, really important. For gynecology as well, get very comfortable with the menstrual cycle. Know what days things happen, know what's normal and what's not normal, and become familiar with the nomenclature. So one of the worst things about medicine is all the abbreviations and the acronyms, and I think obstetrics and gynecology is one of the worst culprits. If I said to you, I've got a G6P4 multip with a, blah, 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 you go, what? What language are you speaking? I'm speaking gynae. So get very familiar with all of the acronyms and the shortenings of things in gynecology. Similarly, get used to the stages of labor. I mean, there's so much to go over. It's a very specialized field, but they would be the main things. Otherwise, the general stuff applies. Get there early, look after yourself, bring snacks, bring food, be organized, be nice, and enjoy. I think I've done a lot of rambling. Let's get to the diary entries. So this is dated the 1st of May 2018. I'm an ONG now, finally. I really, really enjoy it, especially the antenatal clinics. But I've come to the conclusion that A, I'm not a huge fan of gynae. 1, mostly because of my lack of experience, and 2, the presentations, and B, I probably don't want to be an obstetrician. So work is good. I had one shift yesterday when one of the registrars left me for like 5 hours with the reg phone, and I basically shat myself the whole time. But I survived, and I feel like I did a pretty good job. So just a side note, so one of the things I do when I was on the ward board, not the labour ward, is I joined the registrar in seeing people in the emergency department who presented with obstetric or gynecology issues. Sometimes they'd send me first if they were really caught up and busy, and sometimes I'd just join and be kind of like the second person there. I feel somewhat competent in ONG, mainly because I'm somewhat quicker than some of my other colleagues. Everyone is super nice too, so that's nice. Alright, this is a month and a half, nearly 2 months later, the 24th of the 6th, 2018. I didn't really write much, clearly. I finished ONG now, and I'm so sad. I did really enjoy it, despite my hesitancy in week 1. I ended up doing 4 nights as the PHO on call, which was well out of my comfort zone, but survivable. I'm glad I did it for sure, and I know that there are short courses I can do to make more reasonable in the future. So this entry is from the 21st of October 2018, so you'll see that my last entries were back in May and June, and then I went back to ONG like I said, so that was around October apparently. So, my obs and gynae experience was so mixed. I felt both the most and the least helpful I've ever felt, as well as the most terrified I've been for a very long time. I thought about really looking into obs as a career, but now I know that I probably wouldn't handle the terrifying nature of it all. I loved the antenatal things, the postpartum care, the preoperative management, but I'm not cut out for the rest of it. And that's okay. It's nice to have that reassurance that I'm on the right path. I did 4 nights as the PHO on call, as I said, and I survived. The first 2 were breezy, and the second 2 were terrifying. Luckily, despite how incompetent I felt, my boss was really supportive and gave me lovely feedback. I'm really going to miss it. So that's it guys, my ONG experience in a nutshell. Again, you can tell how excited I am about it. It's definitely one of the areas I'm most passionate in, and even in my GP career, I kind of really love obstetrics and gynae. If you have any questions, let me know. If you need me or want me to elaborate on anything, let me know. But until next time guys, stay safe, stay healthy, and I will see you for a very brief video on anesthetics next week. See ya.